So today I'm very honored. Camilla, thank you so much for asking me. And thank you, fellow panelists, for being here. We're going to be talking about grief unveiled. Resilience. So I teach about grief. If you're interested in learning about grief, I offer two courses. One is a 4-credit course, which is offered via Zoom in the autumn term. The other is a loss and legacy in-person learning experience on campus, which is optional for students either taking or have taken the grief class. So if we're going to talk about grief, we should probably start by talking about why do we grieve? So there likely are complex, multiple evolutionary reasons. Vigilance may link to us needing to reunite with others, which may have survival benefit. Our obvious sorrow and pain may show that we are committed partners who are able to attach and be loyal members of a group. It may also indicate to others, because that sort of pain is difficult to fake, that we're in need of extra support from our social networks when we grieve. There are many reasons that we grieve, others as well, but what really fundamentally is the reason that matters to us that we grieve? I mean, why do we grieve? Well, of course, it's because we love. Love is the reason we grieve. And because it's our relationships with those we love that make our lives so meaningful and rich, love is costly, but it's well worth the price. So we have to contend with and we have to deal with grief because it's part of loving and it's part of having a meaningful life. It's a terrible tragedy if someone goes through life without having a reason to grieve, without having people they love. So you may be familiar with Elizabeth Kubler-Ross's 5 stages of grief: denial, anger, bargaining, depression, acceptance. But is that quite how it is? Probably not. We'll talk about that in a moment. But she wrote a very famous book on death and dying, and she did some very, very important work, which opened the door for us to talk about grief in our culture. What she did was she listened to terminally ill people, and she helped them to be heard. She increased public awareness of the lack of appropriate end-of-life care, which was a tremendously underserved need at the time. She testified to the U.S. Senate about problems in the care of terminally ill people, and she reduced the taboo of talking about terminal illness, death, and grief. But her 5 stages were never intended to be prescriptive. It was what she found in a particular sample, and the sample wasn't broadly people who are grieving. It was people who were terminally ill. So the 5 stages are very well accepted culturally. Most of us have heard of them. It might be the only thing you know about grief, officially, in a scientific way, but it turns out that they aren't actually that well supported in the research. Not everyone who's terminally ill experiences the 5 stages. When Kubler-Ross herself was dying slowly from the consequences of multiple debilitating strokes, she explained that she did not experience denial or bargaining, but she found herself stuck in anger for a very long time. One really significant problem and a reason to talk about this is that clinicians may misunderstand Kubler-Ross's work and then be prescriptive with patients, expecting them to fit a model that may not apply to them. The model fits for about 10% of people, actually, who are grieving, but the other 85 to 90% don't grieve in that way, according to that set of stages in that order as described. So conceptualizing the model as having stages can result in people feeling pressure to achieve a certain stage or to have linear progression in their grief, which is not actually how we grieve. She relied on qualitative interview data to develop her stages. And really, we should be getting other sorts of data as well. And she herself acknowledged the limitations of her work, leaving space for researchers to investigate further. So she wasn't committed to this is the final answer to how this works. She was committed to starting a conversation and research and investigation, and she was immensely successful in that way. But if we're talking about what grief actually looks like, it doesn't look like 5 neat stages. It looks more like this. We go in and out of different ways of feeling. We go around in circles and get stuck. We go backwards and forwards and up and down as we go through intense grief. So, I'm going to skip that for now. So most people actually do not need treatment for bereavement, but some do. People have different normal patterns of grieving. So some people are resilient pretty much throughout the process. Others have a period of not having any difficulty followed by a return to have a period of difficulty followed by a return to doing well. Sorry, I've got a typo in there. Some have delayed difficulties, then return to doing well. And some people experience overwhelming grief that is long lasting. And that's maybe 15 to 20% of people. So probably or 80% or more don't experience prolonged grief or grief that's problematic. They still need support, still have a hard time. It is not a walk, it's not a walk through a bunch of roses for anyone, but for people to really be in a position where they need help and they're not doing okay. It's a minority of people, but it's a significant minority. So needing help is more often going to happen if someone has lost a child, if it's a loss due to suicide or violence, if it's a sudden loss of any kind, actually, or for a child who's grieving the loss of a parent or sibling, or someone who's undergoing multiple losses at the same time. So I'm going to share with you an infographic from the American Psychiatric Association about prolonged grief disorder, because the question I get a lot of times is, well, when do I need help? When does someone need help? And so it's controversial, but the APA has added prolonged grief disorder to the DSM. And the question is, the Diagnostic and Statistical Manual, how we diagnose mental disorders in this country, also has been added to the International Classification of Diseases, ICD. And the question is, are we pathologizing a normal thing? And this only applies to a small minority of people who are grieving, but should we be pathologizing it? I would say it makes sense because the treatments that benefit people, because treatment helps. And if we don't classify it as a disorder, we can't get insurance to pay for it, and people need to be treated. So while I don't love the notion of pathologizing grief, there is such a thing as pathological grief. And if people are stuck, we want them to be able to get treatment, and we want them to not have a barrier to treatment of not being able to have it paid for by insurance. So I personally am delighted that we now have prolonged grief disorder in the books. It used to be there was a 1-year exclusion and a 2-year, but we had exclusions for when people could be treated, and it more or less denied people treatment. And we don't want that. So prolonged grief disorder happens when someone loses someone close and they experience an intense yearning or longing for or preoccupation with that deceased person. The bereavement lasts longer than social norms and causes distress or other problems functioning. It's not just feeling sad that you miss someone. It's when it's getting in the way of your ability to function in life for a very long period of time. It's normal not to function normally for a while after a loss, but eventually we're able to resume social roles and obligations. So symptoms that there's an identity disruption. So maybe feeling like a part of yourself has died, a marked sense of disbelief about the death, even after an extended period of time, avoidance of reminders that the person is dead, intense emotional pain. And this can also take the form of survivor's guilt related to the death, difficulty with reintegration, difficulty with getting and having a life going on now, emotional numbness, a very strong feeling that life is meaningless, and intense loneliness. So feeling alone or detached from others. And when someone's struggling like this, and it's been over a year since the loss or over 6 months for children or adolescents, and it is making it very difficult for the person to function, we need to think about help for the person. So if grieving is preventing you from engaging with life or having a meaningful life, or if you are thinking you may want to harm or kill yourself, then it is time to get help. And I'm going to be sharing my slides after I fix a couple typos, but I'll be sharing my slides today. And I've got a list of resources here for you. These resources are not exhaustive, but they're a good starting point. So we've got suicide prevention, we've got Veterans Crisis Line, we've got some international suicide prevention, infant loss resources, a variety of information that I think will be helpful if you need it. I also have the Association for Behavioral and Cognitive Therapies, their Find a Therapist link, which is very useful. So how can we support people who we love who are grieving? So most importantly, I think we need to remain present in the bereaved person's life. So regularly call, regularly text, and if possible, regularly spend time with the person you're supporting. I love you and I'm thinking of you. How are you doing today? May I bring you over a meal? Can we schedule time to get tea or coffee? Can we put on the calendar right now? Often people have social support early in the process, but it's not sustained. But grief's a marathon, not a sprint. So put it on your calendar. You're supporting a friend, put a reminder on your calendar. I'm going to call on Tuesdays. Maybe 6 months go by and you back it off to every other Tuesday. I don't know. But make it a regular thing. It takes a lot of support to help a person who's going through a major loss. So how else do we support people who are grieving? If the person has a different cultural background than you do, familiarize yourself with any cultural practices or expectations. For instance, in some cultures, it's expected to send flowers, and in others, it would be hurtful because flowers are for the living. So make sure you have an idea of what would be comforting to that person. And people have differences as well. So be sensitive to what the person you're supporting feels like. It may or may not align with that person's culture, but aligning with the person's culture is a good place to start if you don't know something else to do. Along these same lines, what's a comforting belief for you may not be comforting for the person you are supporting. For instance, please don't tell an atheist that everything happens for a reason. Actually, I'd say don't tell anyone that everything happens for a reason. It's a good phrase to eliminate because that one's usually comforting to the comforter, but not the person who's grieving, right? Everything happens for a reason. There's a reason this terrible thing happened. That's not helpful. If the loss potentially involves stigma or shame, like suicide, substance abuse, something that the person may not be getting as much social support for, or may have some shame or anxiety around, find something kind and true to say. I'm so sorry you're hurting. I miss the name of the person's laugh. I miss us all spending time together. Find something true and kind to say. The person who is grieving may have complicated feelings. They may feel very guilty about any negative expression about their loved one. They may feel shame. They may feel a lot of different things. They may not be getting as much support because then there's a stigmatized loss. Often there's a much less support. Meet that grieving person where the person is. A lot of times, if you can, it's good to redirect rather than blaming the person who, say, had an addiction. Blame addiction, blame the substance. Nobody woke up one morning and thought, gee, I'd love to have addiction. Gee, I'd love to have major depression. Gee, I'd love to have whatever the thing is that made it so hard for that person to continue living. For instance, if it's a suicide or an overdose. Okay, something that gets in the way for all of us when we're helping people who grieve is that we want to believe the world is just. We have this, it's threatening to our worldview that bad things happen to good people, and yet bad things happen to good people all the time. And so we find ways, and we're all prone to this. It's a cognitive bias that we, as humans, tend to engage in. We tend to blame victims for what happens to them. It's much more comfortable, and the world's much more controllable if we think, well, weren't there any symptoms? Or, well, didn't this person do A, B, or C? Well, were they doing such and such? It's not helpful, and it's not accurate. If you think that the world's always just, that doesn't account for bad things happening to good people and misfortunes that happen to people, and we blame them on them. So try really hard to not engage in that. Tolerate the fact that there's pain and injustice in ways in which the world isn't just or fair. Instead of blaming victims, find some way to make the world a little more just and kind and better around you, whatever that is. What else can we do? Well, it's easy to put your foot in it. When someone's in the intense part of grieving, it's almost like the person's a crab with its shell off. They aren't protected and everything hurts much more than it otherwise might. So if you accidentally say something that lands wrong, that you're grieving, the person you're supporting who's grieving finds painful, or if you're not sure what to say, you might want to think about saying something along the lines of, I don't know what to say, but I'm here, I care, and I love you. And that will go a long way. You don't have to be perfect in everything you say and do. You do have to show up. Okay. So what about those of us who are in the throes of grief ourselves? Like, how can I be resilient? How can I move on? How can I carry on? Make a distinction. We don't move on. You don't leave the people you love behind you. Instead, you find some way to carry that person with you. That's what we do. We find a way to carry that person in our memories and in our hearts with us as we move forward. So there's some really important reasons to be as resilient as you can be and to do everything you can be to get through when you're having a hard time. Think about the people who love you. If you have a pet, think about the pet who loves you. Think about the fact we live in a world that's having a lot of troubles and needs everyone to do their best to make it kinder and better. There is something you can do to make the world kinder and better. And you have to be here to do those things. And think about future you. So if you cannot help but hurt right now, in this moment, if you're acutely grieving right now, and there's probably at least a few people listening right now who are, work to make your world a little better for future you. That future you may want to be happy. You right now might have to suffer. It might be really horrible right now and really painful and terrible. But think of future you. Think of future you like you would think of a child you really, really love. Maybe a niece, a nephew, someone you love a great deal. And think about doing for future you the way you would do for that child. Make choices in the moment now that leaves it possible, leaves the door at least a little bit open for that future you to have a chance to maybe be happy or at least happy enough again. It's really hard to do. It's really, really hard to do. But if you can do that, you're leaving it open. So when things are terrible, keep picking up the phone when your friends call. It's not your job not to be at the edge of the abyss. It's your job to yell for help if you find yourself there. You're at the edge of the abyss, yell for help. Keep doing the little things you can do to make things better for future you, even if it's awful right now for current you. Think about, I have to hurt right now, but what can I do for future me? Future me would like to have paid the bills. Future me would like to have kept the job, or whatever it is that future you is going to need to have a chance. Give future you that chance. So when things are terrible, we're challenged to change ourselves, is what it amounts to. So in his 1946 book, Man's Search for Meaning, Viktor Frankl wrote about his experiences in concentration camps, and during which he lost his family, his wife. It was pretty tragic and terrible. And he wrote, when we are no longer able to change a situation, we're challenged to change ourselves. So there may be a time in your life when it will help you to embrace that challenge. If you can't change what is, change you. So make sure as you're grieving that you call on your friends, engage your social support, pick up the phone when they call you. If someone asks what they can do for you, say, please keep calling. It's hard for me to pick up a phone right now. It means so much when you call me and text me. Engage with your social network. So William James, the first American psychologist, the founder of the psychology department at Harvard, he said, he wrote, certain persons do exist with an enormous capacity for friendship and for taking delight in other people's lives. Such persons know more of truth than if their hearts were not so big. So let yourself love the people around you. Engage with them. Exercise, even modest amounts, even little walks, makes a big difference. It turns out that exercise, especially aerobic exercise, anything that gets your heart going, so going for a brisk walk, improves how your brain functions. And I could give a much more detailed answer, but here we go. So exercise reduces depressive symptoms, also reduces symptoms for a variety of psychopathologies, and in general improves our health. But part of how it does this is it improves neurotrophic factors and improves our ability to shift attention. So the ability to better shift our attention is really helpful in grief because we often find ourselves ruminating and stuck in negative thought cycles. When you exercise, it gives you a boost in terms of your ability to shift your attention to and from things. So this will help you as you grieve, believe it or not. Sleep matters. So lack of sleep is a causal and a maintaining factor in mental health issues. So one of the most important questions you can ask is someone who's grieving, are you sleeping yet? How are you doing on your sleep? That'll give you a good snapshot of how the person's doing, actually. And as you yourself are grieving, what can you do to improve your sleep hygiene? Even a little bit. Sleep matters. And of course, some of the symptoms can disrupt sleep, but work on your sleep hygiene. Lack of sleep is a risk factor for many other health problems as well. Bad enough you're grieving. You don't need to have any other health problems on top of that. Okay. Here are 3 helpful books you can read. I've already mentioned Viktor Frankl's Man's Search for Meaning, but 2 other books I frequently recommend are When Bad Things Happen to Good People and Resilient Grieving. And in fact, these are books I tend to assign in my classes. So another thing you can do, whether it's for yourself or to help others, is you could take a class about grief, which I offer. And here I will read you my course description so you know what we do in my class. And I will say that a couple of the wonderful people who frequently come and are guests in my class are here on this panel. So grief is ubiquitous. At some point in our lives, each of us will grieve, yet it can be a taboo topic. This course provides an overview of the major theories, modern research, and current issues for understanding the phenomenon of grief. We examine psychological as well as anthropological and sociological research articles so we can better address questions such as, what is grief? Why do we grieve? Did Neanderthals grieve? Is grieving over the death of pets a new phenomenon? It's not. Is there more than one normal pattern of recovery? Are there effective treatments for people with complicated or prolonged grief? What are some of the grieving practices of people in different cultures at different times in history? Is it possible to have a meaningful and worthwhile life despite grief? What does it mean to be resilient? We read and discuss a whole bunch of fascinating materials, and we have amazing guests, and you will enrich your knowledge and understanding of this important universal topic if you take this course. I also offer an active learning on-campus weekend where we focus on meaning-making creative activities and address collective grief. We go to the Peabody Museum. We go, weather permitting, we take a guided tour of Mount Auburn Cemetery. People learn about ethical wills and begin creating their own legacy writing. It's a really surprisingly joyful weekend. And before I sign off, I think I want to just say, if you're enjoying this presentation, I'll have the link in my slides as well. You might want to consider joining the Harvard Extension Student Psychological Society. And I've got the little QR code in there so you can do that if you're interested in doing so. And so thank you for your kind attention. And those are my slides.
Thank you so much, Dr. Meyersburg. I really appreciate you agreeing to do this event with us. And we're so honored. I think I was in the class when your first grief class, when you just started, and I was in the first loss and legacy class, which incredible things actually came out of that, where soon, hopefully this year, we're going to be able to put the name of one of the, actually, he was a Harvard faculty, he was a Harvard alumni, but he never got his name on his grave. And this came about by the tour that Dr. Meyersburg had set up at the Mount Auburn Cemetery, which honestly is the most beautiful cemetery I've ever seen. It's so beautiful that they hold weddings there. So, but so something amazing is going to come out of the course that you did on top of the knowledge and the supportive information that and resources that you gave us. We're now also going to be able to put this guy's name on his grave after over 65 years of being unrecognized. So that was another incredible thing. You do so much for everyone. And so I really appreciate you being here. And thank you for being here for our anniversary of our society. Thank you. And now I want to introduce, we're so honored to have Miss Pam Albert. She was actually, let me see if I can pull up the slide. She's actually incredible. She's an RN, BSN, CPTC, and CBF. I'm going to have her explain that. But she's here to talk to us, especially about donations and transplantation. I believe she's the best person you can actually go to talk about donor services and how it actually helps people through the grieving process. It's something that I actually didn't know about until Dr. Meyersburg had her as a guest speaker. So I really appreciate that she's here, and I'm gonna hand over the webinar to Miss Albert.
Thank you, Kimia. Can everybody see my slides? All right. All right. So I want to
Not
thank.
yet. I can't see
Not
your slides.
can't see my slides. Okay. Let's try this again.
While you're doing that, I wanted to tell you that one of the students who was in our class last time, whose spouse was on the kidney list, got a kidney.
Oh, so that's great news. Now, can you see my slides? Okay.
Yes, we can.
Okay, perfect. So I want to thank Cynthia and Kimia and the Harvard Extension School Psychology Student Society. That's a lot to say to get all together, for their very kind invitation to be part of this presentation, and to Cynthia for inviting me to talk to her class. It's a wonderful experience, and I am yet to take one of her courses, but that's on my bucket list. So let me talk to you a little bit. I want to talk about the body of work that I've been associated with for the past 34 years, which is working with families who have experienced a sudden and tragic loss, and to talk to them about the possibility of saving the lives of others while creating legacy and meaning around the death of their loved one. So as Kimmy has said, a lot of people aren't familiar with the worlds of OPOs, or organ procurement organizations. So I just want to spend a couple of minutes talking about the organization that I work with. So we were established in 1968. We are the oldest organ procurement organization in the United States. We cover all of New England except for the upper northwest corner of Vermont, and we cover the island of Bermuda, not because we're the closest, but because they have a transfer pattern for transplantation to both Mass General, the Brigham, and Lahey Hospital. So we serve 14 different transplant centers in our coverage area. We cover 197 acute care hospitals. We have a population base of about 15 million people. And to give you an idea of sort of the number of families that we work with, the number of recipients that we help, in 2023, we had 549 organ donors, which resulted in 1,670 organs recovered and transplanted. And in regards to tissue donation, we worked with 1,733 tissue donors, which resulted in 434,322 tissues recovered and thus transplanted. So I've been working in the field of donation and transplantation for 44 years. The first 10 working on the transplant side, and the last 34 working on the side of transplantation. So I wanted to start my portion of the program with two quotes, one from Margaret Mead, one from C.S. Lewis. And Margaret Mead wrote that when a person is born, we rejoice. When they're married, we jubilate. But when they die, we try to pretend that nothing happens. And we as a society have a really difficult time talking about death. And if we can't talk about grief, death, then it makes it hard to talk about our grief and other people's grief. And although death is a topic that each one of us will face at some time in our lives, whether it be talking about what will happen when we die, what we'd like to have happen when we die, what might be part of our legacy when we die, or when someone you love dies. And we know, it's certainly in the work that I do, that people can die at any age, and being ready for the end of your life is important, no matter what your age is. And often when people do make the decision to place their name in the donor registry, to have their donation that or part of their legacy be helping other people, they often do that, but they don't have a conversation with their family, because talking about what's going to happen to us when we die is an uncomfortable conversation for both the person who's leading the conversation and often for the people that they're trying to share that information with. And so when it comes to donation, that lack of a donation or a conversation about what you want to have happen to your body with your family is the most common concern or obstacle that we face when we're thinking about how will we frame a donation conversation for the family. And certainly in the years that I've been in this and the number of donor families that I've had the honor to work with, we know that for those families that have said yes, They talk about the solace and comfort that comes from saying yes to donation, and that it was a very important part of their grief journey. I particularly like this quote from C.S. Lewis that says, "No one ever told me that grief felt so much like fear." And that's taken from his book, A Grief Observed, another good book to have in your library. Potential donor families, I've had chances to talk to them individually and in a group. And when we've asked them, what do they fear most about the death of their loved one? Some of the answers that they shared were they feared that their life as they knew it will never be the same. They had fear about what the future may be or will hold for them without that individual in their life. They talked about the fear of being alone, the fear that I won't know how to cope with my loss, my own grief, or the grief of those close to me, the fear that I'll do grief wrong. There's no wrong way to grieve. It's what works for you. The fear that I cannot go on. And lastly, the fear that I or my loved one will be forgotten. So I had the opportunity to work with a wonderful transplant social worker many years ago at one of our major trauma and transplant centers. And she shared a quote one time with a group. We asked her to be part of a presentation. We were talking to nurses in the ICU. And her quote that I think really summarizes where we as donation professionals and transplant professionals often first find families and ourselves as we begin to think about how to frame a family donation conversation. And Kelly said, "It's at the beginning of a family's grief, when their own hope is taken away, that we ask them to invest in the lives of strangers through the life-saving or enhancing gift of donation. And we ask them to make an investment in their own later stages of grief, stages that in the moment they cannot imagine ever reaching." And I think it really summarizes our conversations with families, whether it be organ or tissue donation, happens within the first few hours following the pronouncement of death. And we know that donation is a wonderful gift and that act can save or transforms life. And in talking to families who have said yes, they have shared that it transformed their grief. We found that offering donation in those early hours following the declaration of death, many families have said that they latched onto it like a life preserver, sometimes often sharing that the opportunity gave them a sense of regaining control on a day and at a time when everything seemed uncontrollable. And often said that the true benefit and meaning, however, of this decision most often happens over time, that what they feel in the immediacy of that discussion and what they feel a week, a month, a year, many years later is different. So when we think about what does the donation experience feel like and how is it linked in a family's grief journey? And when we think about, for our organization, we have a department called our aftercare department, which supports families from immediately following the donation to up to a year after, but we follow many of those families for many, many years after. And when we think about the goal of the work of aftercare, it's really the beginning of how can we as professionals alleviate some of the family's grief. That really becomes the goal of the work that we do. We know that comprehensive communication with and support for the family over time is paramount. And we know that how this is done has long-lasting effects on their ongoing grief journey and their bereavement. And that providing optimal care for the potential donor family members is no less than what each of us would want for ourselves, were we to find ourselves in a similar situation. And we really want to create a human death experience, not just the medical one that meets the needs of the family while still advocating for those who wait, for those who believe that the best aspect of our job is telling their story, their needs to the individuals who have the potential to save or change their lives. And we know that the failure to offer that opportunity of donation can deprive a family of the ability to honor their loved one's decision if they place their name in the donor registry to become a donor, to contribute to their loved one's legacy as they make a gift, as they describe, of love and life, to help those who are waiting. And offering the family the opportunity of donation may also help the family to find some measure of solace, while failing to do so may negatively impact the family for years to come. So when we think about the provision of support to families facing the death of a loved one who is a potential organ or tissue donor is essential. Such support helps to maintain that balance between society's goal and our goal as an organization of increasing donation, as well as respecting an individual and a family's right to self-determination, to have information provided to them in a timely manner, in a way that they can understand, so that they can make a decision that is informed, proactive, and enduring. So when we think about who's waiting, that other half of the people that we advocate for, so there are more than 103,000 individuals waiting for a life-saving or enhancing organ transplant. We also know that 1 in every 20 Americans will need a tissue transplant at some point in their life, and that annually in the United States, 2 million tissue transplants are done. We also know that as experts in communication have insisted for years, effective communication requires being alert to what is said by the family as well as not said, being attentive to literal and symbolic communication, to watch body language as they watch ours, to look at the differences between individuals and between members of diverse cultural groups, understanding rituals that may need to be considered as part of the death experience, which then become part of the donation experience. And the literature states that grief can impair an individual's cognitive ability to take in and understand. So families have shared with us that they heard the information provided to them, and yet when they reflected back on it in the moment, they couldn't put the words back into a sentence that made sense to them. Thus, competent and empathic sharing of information between caregivers and family members is crucial in bereavement-centered care. I particularly like this quote from Henry Nouwen, a Dutch Catholic priest, professor, writer, and theologian. And there are 2 sentences in particular that resonate with me. The first is that compassion is hard because it requires the inner disposition to go with others to the place where they are weak, vulnerable, lonely, and broken. And the second is if we run or flee from it, we ignore our greatest gift as caregivers, which is our ability to be there, to listen, and to enter into solidarity with those who suffer, or in other words, to tap into our empathy. And it's sometimes engaging with families often requires little to no words on our part, just the willingness to listen with a beginner's mind, without preconceived notions based on information that may have been shared with us by others. And for the work that I do every day, this is where we most often first cross paths with families, where they are weak, vulnerable, broken, and lonely. I also read an article that was entitled Being There, the Fine Art of Consoling Someone. And I wanted to share with you a quote in that article that really resonated with me. The article said, spending time comforting others is a task that requires real skill. Do it well, and it's effective and rewarding. Do it clumsily, and you'll end up feeling useless and depleted. And the author said, it really comes down to 3 words: to be like water, because water is fluid, yet it tends towards stillness and it's reflective. And if you can embody these characteristics, you'll be able to be of benefit to anyone in need. So when we think about what the act of donation truly means, it's the ability of a total stranger in a selfless act to make a decision that allows for a second chance of life for those in need and provides them not only with the gift of life, which is in reality the gift of a lifetime. So I'd like to share with you a story of a young lady named Asako, who I had the honor and privilege of working with her family many years ago. And I think in telling her story, it should encompass all of the things that donation can do to help a family in grief. So 37 years ago, in the spring of 1977, we received a referral from one of our large trauma hospitals. And it was for a 24-year-old foreign exchange student who was studying in a local community college here in Massachusetts named Asako, who was injured in a motorcycle accident. She was riding on the back of the motorcycle driven by her host family's father. He was killed instantly. She was brought to the ER of a large trauma center with a devastating brain injury. Her parents, who lived in Japan, were notified and were due to arrive at the hospital later that day. The nurse who made the referral shared that her parents are non-English speaking, and she finished the statement with, "They're Buddhists, and so we know they're never going to agree to this." And so I asked for a translator to be available and shared that I'd be there in an hour. After the staff had the opportunity to share with her parents the seriousness of her injuries and that she had been declared dead by brain criteria, I was brought in to talk to the family. During part of the discussion through the translator, Asako's mother pulled out a packet of letters from her purse that she had received from her daughter while she was here and pointed to a particular letter and then a particular passage for the translator to share. And it stated that while she was here in Boston, she had had the opportunity to go to Boston Children's Hospital, where she met a young boy from Japan who had recently received a liver transplant. So in 1997, brain death was not an accepted belief or method of declaring death in Japan. Asako wrote to her parents how sad it was for this child and his family to have traveled so far from home for their family to have this opportunity for transplant. She then went on to state that when she got her Massachusetts driver's license, she registered herself as an organ donor. The family shared through the translator that we decided to donate our daughter's organs after we talked for about 7 hours. Then 7 of her organs were transplanted to 6 people, and they recovered their lives. They shared that if she could answer our question of what to do, we know that she would say yes, because she put that sticker on her license. Her mother said that we make this decision to respect her own will, and that we made sure that this would happen. And they said yes to begin the process of donation. So one of the recipients of Asako's gifts was a 66-year-old woman named Doris, who received the gift of Asako's liver. Following her transplant, she asked our aftercare department if she could send flowers to her donor family. Now, that's something that was usually pretty easy for us to be able to accomplish. However, to do this with a family in Japan was going to be more technically difficult than we thought it might be. So as they lived in Japan, we talked with her transplant coordinator and said, we're going to share a little bit more information with Doris than we usually do to help her understand. And so we said to her that her donor family lived in Japan, and perhaps she might want to start with a letter, which we had translated through the Japanese consulate here in Boston. So that letter went back to the Mizawas, and they then continued to write back and forth with Doris. The following year, every year at that point in time, we had a donor family recognition ceremony where we invited all of the donor families from the previous year so that we could recognize the gifts that they had given. So we made the decision to send an invitation to Asako's family, never thinking that they would take us up on our invitation. And to our surprise, when they said yes, they also sent word to us that they were going to be in Boston. The reason they were coming was they were going to be in Boston to attend the graduation ceremony, what would have been her graduation ceremony from college, as that university was granting her a posthumous degree. They did, however, have a request for us. They said that they would like to meet Doris in person. And so we went around making sure that that would happen. Over the years that ensued, Doris and Asako's family kept in touch. They went to Japan to meet them. And I also, very luckily, was offered the opportunity to give a lecture at a transplant conference in Japan. And during that time, I took a couple of extra days to spend with Asako's family. So time continued to go on. They continued to send letters back and forth. And so many years later, I got a call from Doris's son, to which my first thought was, oh no, something must have happened to Doris. But no, it was on the occasion of Doris's 80th birthday, and a very celebratory party was going to be held in New York, where she lived. And they shared with me that Asako's family was coming, and would I come as well? So got in my car, drove to Albany, and had the chance to talk to Asako's parents. It had been quite some time, many years, since I had the opportunity to talk to them. And I asked them how they felt about the decision that they had made so many years ago. And her father, who was the very quiet one in the family, shared with me through a translator that we never regretted that we donated her organs. It was a natural decision because it underlied her own will, and that people have to help each other when they can. He went on to say, for 24 years, she always shined brilliantly in our lives, cared for others, and smiled gently. And although our family and friends fight back tears, we celebrate her dream, which was to become a donor, which finally came true. She taught us that man cannot live alone, and she became the bridge between us and Japan. And Asako's gift gave Doris 23 extra years, which allowed her to live a rich and vibrant life. And she died at age 89. I still, to this day, continue to hear from Asako's family every Christmas. And so when I think about what can donation mean, not only to an individual's legacy, as Asako's has continued to over these many years, but what it also means to the family. And I think that this story illustrates what could have been a clash between our culture and their religion, because at that point in time, this was not an accepted practice. But instead, it continued to provide Asako's family with ongoing solace and comfort. So when we think about what distinguishes ordinary bereavement care from extraordinary bereavement care, and really is a belief that we have something of value to bring to a family's experience. And we do that through the capacity to try and see the experience through the eyes of the family, to try and tap into our empathy to meet them where they are, and the desire to make a difference in the life of each family by striving to co-create an experience that will help them as they begin their process of healing. And so I want to close my portion of our time together with a thought from C. Murray Parks. And he said, with proper training and support, we shall find that repeated grief, far from undermining our humanity and care, enables us to cope more confidently and more sensitively with each succeeding loss. And so I thank you for your time and for inviting me to this wonderful program. I'm happy to take any questions that anybody has, or we can wait till the end, whichever is easier.
Thank you so much. I really appreciate that. That was such a touching story. And thank you for sharing that story. It's beautiful. And this is a reminder also that the video for this webinar is going to be posted on our YouTube. So for those who couldn't join, they can still take advantage of the wonderful information you guys are providing today. And yes, that was definitely got me. That story got me. But thank you for sharing it.
You're welcome.
And now I would like to welcome, let me see if I can share my page. Yes. Okay, we have another extraordinary guest, Janie Acosta. She's a RN, BSN, and accomplished executive director with expertise in assisted living, memory care, dementia care, home health, and hospice. We're still honored to have you, and I'm going to hand over the floor to you.
Thank you. I'm going to just start out with a little introduction before I go to my slides. So just want to say so far I've heard a lot of wonderful things, and this is a well-rounded panel, it looks like, and it's an honor to be here amongst all of you, scholars and professionals. Truly humbled and grateful to be here. So thank you, Kimia, so much for asking me to do this. I'm pleased to be able to share my experience with you on this sensitive topic of grief and loss. A little bit about me, as Kimia mentioned, my background, I'm an RN. I've been a nurse for almost 30 years. I started out in assisted living. I worked also doing home health and palliative and hospice care. Truly a patient advocate. And I love what I do. I love my profession. I'm currently in management as the executive director at Vista Del Mar Senior Living in Long Beach, California. It's in a 300-bed licensed assisted living facility. We also have a memory care unit, and we have currently about 30 residents on hospice in our community. I'm also enrolled in a master's program as I'm working towards obtaining my adult geriatric primary care nurse practitioner's license. So I'd like to share a little bit about my personal story, which has influenced me in my professional life. When my mother was pregnant with me, the same time she found out she was pregnant with me at the age of 39, she also found out she had breast cancer. She died before I turned 2 years old. I don't remember her. I've heard many stories of her tragedy and sacrifice to bring me into this world. And she actually named me after a nurse that took care of her when she was sick. Growing up, it was really hard to understand how I could miss somebody that I couldn't remember. So it was grief is a process, but certainly this was complicated grief for myself. For a long time, I didn't allow myself to grieve because it just didn't make sense. As an adult, I realized I needed to grieve. I needed to grieve that loss. And so my father, he wasn't fit to raise me, so I was raised by my aunt, and I had minimal visits with him. When I was 18 years old, he actually had a major brain aneurysm and ended up on a ventilator. We had to make the decision to let him go. And it asked me if I wanted to be there when they took him off the machines. And something inside me told me that I needed to forgive him for not being the father I wanted him to be, and that he shouldn't die alone. This was a moment of grace I had at a young age. I stayed with him and watched them take him off the machines, and I watched him take his last breath. It was a really unusual experience. It seemed that he was already gone before they unplugged the machines. Like his spirit had already left the body. It was the first time I had seen that this human body was just a vessel, and he had already been gone. I also lost my grandparents. They all died by the age of 16. I think this is one of the reasons I love working with the elderly, to fill that void of the grandparents I lost as well. I experienced many deaths at a young age. I watched my aunts and other family members as they would hold vigil at the bedside of loved ones who were dying. They would talk to them and let them know that it was okay to go. This experience was foundational in my ability to help other people when I entered into hospice care. I had an acceptance that death is a part of life and not to be feared. In some way or another, my career has involved walking people and their families through their end of life journey. So I'm going to share with you some basics about hospice that I feel will be useful to share with you. So I'm going to go ahead now and try to share my screen. All right. All right, everybody can see? All right, so much of my experience is clinical and worked in hospice for about 10 years hands-on. And most of it was doing admissions. I'd be the first one to meet with families to discuss hospice, had many difficult conversations with family members. I'd meet with them either at the bedside in the hospital, it could be an assisted living home, or at their home. Sometimes what I noticed is that the doctors didn't really do a good job of explaining prognosis, and they would leave that up to the hospice team. So it made for some challenges when having to go through explaining, why this referral was being made and how we could help. A lot of people have a fear of the word hospice. They think that it's for the last days of life. They think that they're giving up or giving up hope. And accepting hospice is not taking away hope. It's actually accepting help and support for the patient and their family. And what I've noticed is that the grieving starts before the death of the patient. They get a terminal diagnosis, and the family and the patient, depending on where they're at with their disease process, they start going through those stages of grief. And as Dr. Meyersburg talked about, it's not linear. Some people vacillate, some people will experience, they'll go back and forth between these stages. Sometimes they're quickly into acceptance, and it just really depends on the individual. But that's what I've noticed, is that grieving starts, before the patient dies. And where my role comes in is really explaining how a hospice can help. One of the first questions I'll ask is, tell me how things have been going in the past 6 months. And a lot of what I'll hear is, oh, we've been in and out of the hospital. There's been falls, trips to chemotherapy. They're starting to sleep more, they're functionally declining, less and less able to care for themselves. And then there comes a point where they're too weak for aggressive treatment. Let's say they have cancer and they're going through chemotherapy, and they really still want to go to that chemotherapy, but they become too weak to go to their appointments. But they don't want to give up that chemo, and what I've noticed is oncologists will continue to offer it. The patient, can have it as long as they want. So I do my best to try to meet where the patient and the family, where they are. And that's been mentioned a couple of times today. And when we're dealing with people that are going through this process, I like to explain that hospice is a choice. This is a choice and an option. Sometimes if you have an appointment next week for chemotherapy, today you're too weak to make that appointment. Today you need the help. Today you need the pain management. Today you need the hospital bed. Today you need these things at home to offer you some support and some relief. And if you get stronger and better and you want to make it to that, chemotherapy appointment, then that's still an option, right? So that's another misconception I have to go through. You can come on and off of hospice, and there's no limit to that. I'll also talk about, curative versus comfort care. So again, doctors aren't always really good at explaining prognosis. So we'll talk a little bit about, is there something we're curing here? What have you been told about your diagnosis? Have they used the words terminal? Is what we're doing now palliative only? So there's a lot of discussion on where are we at? Are we prolonging life, or are we prolonging suffering? I'll address fears and misconceptions about hospice, meaning that you're giving up. Hospice is a place. Sometimes hospice is a place. Sometimes hospice can be done at home. And then some people think people will die quicker on hospice because once they accept hospice, they're accepting death. And that's not true. It's not going to change the outcome. Whether or not they accept hospice, the patient is still dying, still going through an end of life process. And oftentimes what I hear from family members, once I've kind of gone through this process of explaining all of the support that's going to be provided, is that I wish I had known about this sooner. I wish I had known about this sooner. They don't feel so alone. So some basics, the patient must have a diagnosis of 6 months or less if the disease process runs its usual course. Most common diagnosis is cancer. Of course, there's other diagnoses too that people can be admitted to hospice for: end-stage heart disease, lung disease, dementia. Sometimes it's a combination of things. The focus is pain and symptom management, physical, psychosocial, and spiritual. I like to let them know that the patient is in charge. A lot of times when you're going under curative measures and being treated by physicians, they're directing the care. You need to do this, you need to do these tests, you need to go for these treatments, you need to take these pills, and when patients go on hospice and they're tired of all of that stuff, they get to choose what they want and what they don't want. And most patients want to die at home. When asked, if and when the time comes, do you want to be in a hospital or do you want to be at home? And most people, I think, would say and do say at home. The hospice team, I worked on hospice on the other end when I was working in assisted living in the beginning, and I knew about hospice, but it wasn't until I actually worked in a hospice that I knew how much was entailed in actually the care of each patient. Each patient is assigned a nurse, a doctor, a social worker, a home health aide, chaplain, and they have volunteers. And of course, the patient and the family are part of that team. And each week they have a meeting, an IDT meeting, to discuss the care of each patient to make sure that they're providing the most comfort care for each patient. And the needs at the end of life, what I found is really support and guidance. And from the nurses and the social workers and doctors really help walk people through that process, letting them know what to expect, letting them know what symptoms are to expect and what's normal and what we can do to treat those symptoms. They also, if they're at home, equipment's provided, oxygen, medications, hospital bed, shower chairs, any type of equipment that might be needed at home. And a lot of people don't know that this can be, they can be at home and have all this support. Also, the social workers provide resources and placement if needed, if they can't care for them at home. So the dying process is unique for each person. There's some common signs and symptoms, but it's a natural process. The body knows what to do. When they get to that point, when they're in the active dying process, the body's systems start shutting down. There's changes in the respiratory pattern, changes in how the heart's beating, changes in blood pressure. They're decreased urine output. They stop eating and their skin changes. So these are the things that we explain step by step to families and let them know what's normal and offer things that can help with relief. One thing I wanted to make a note about was about artificial nutrition and hydration. Sometimes people, and this is a common thing, that people think that they're starving the patient, that they're starving their loved one if they're not feeding them or giving them hydration or nutrition. And actually, this can be more difficult on the dying process. If the body systems are shutting down, it's more difficult on the patient. They can go into fluid overload. their heart, and their lungs. I've actually seen folks where they want to try to prolong somebody's life by continuing to give the fluids and the feeding. I was in a hospital once where they were waiting for a loved one to show up to fly in from out of state. Like, well, can we just continue the, the fluids? I want to continue the nutrition until they get here. Like it was, but the patient was dying, and she ended up drowning in her own secretions. And so, unfortunately, that wasn't one of the most pleasant, experiences. But we do our best to educate the families, and the patients still have the choice to continue those measures if they want to. Morphine, that's another common medication used at the end of life. Sometimes in the hospital, it'll be a morphine drip. At home, it might be sublingual morphine. But some people think that they're going to kill their patient. They're going to make them die sooner, and that's not true. What they're dying from is the cancer. What they're dying from is the end-stage lung disease. The morphine is offering relief and comfort. Respiratory suppression is a side effect of the morphine, right? It decreases respirations, but that really is the desired effect when somebody is struggling to breathe at the end of life. Sometimes their respirations get really rapid and shallow. So giving them a little sublingual morphine under the tongue actually helps relax those muscles and helps them breathe easier. But this is a really, really common misconception. I even had nurses at the bedside refuse to give it because they think they're going to kill their patient. So it's a lot of education that we provide to all of the support team. I actually used to do hospice at an inpatient at a hospital. For a hospice, we had a contract. So we actually did hospice in the hospital at the bedside. And that was a unique experience. Sometimes the patients were too critical to transport home. In that case, we did a morphine drip. Anyhow, so the focus is managing symptoms, pain, agitation, restlessness, sleep, and constipation. Being constipated can really be uncomfortable. I had a hospice palliative physician that I worked with, and one of the first things I learned from him was whenever you go see a patient, these are the 4 things you look at: air, pain, poop, and sleep. How are they breathing? How are they sleeping? And are they constipated and in pain? So the focus is providing comfort, offering reassurance that they're not alone in this process, providing a calm and comfortable environment. Always assume the person can hear you. Trust the process. And it is a privilege to care for the dying. It's always been an honor to be able to walk people and walk patients through this process. It's not easy, and being able to offer that support and guidance is priceless for these families and these patients that are going through this. So environment, keeping pictures in the line of sight, there's lots of things to consider at the end of life. Bed placement, are they near a window where they have a nice view, playing music, and then supporting loved ones and saying goodbye. Sometimes they need that push to tell their loved one that it's okay to go and that they're going to be okay. And this is something that a lot of hospice nurses will help the families through. I wanted to tell you one final story, and I love the storytelling. And Pam told a beautiful story about Asako. And, I had never met anybody else that was with child and had cancer until my friend Audrey. She had never had children. Her husband went through IVF, and she got pregnant with Bodhi. At the same time she found out she was pregnant, she found out she had pancreatic cancer. And it hit home for me. It hit home for me quite a bit. When I was little, they told me I was a miracle baby, and I really didn't like hearing that. But when I met Bodhi, boy, I was like, oh my gosh, this is a miracle baby. And I was able to be there for my friends and be there for Audrey. And she passed away before he was 10 months old. And I was I got to walk her through that process, being in hospice at the time. And I got to really watch what they went through and help them go through it. And her husband was never going to accept hospice. He was pushing her. He wanted her to live, of course, obviously, and never accepted death. And it wasn't until 2 days before she passed away, she was in the hospital, and the nurse said, you know, she's dying. She's dying. Do you want her to be here, or do you want her to be at home? And he needed to hear that. Like, he needed to hear that. And so it said, if you take her home, she can be with her baby. And he had to hear that. And he asked her, and she had been somewhat slipped into a coma, and when he asked her if she wanted to go home to be with her baby, she opened her eyes. And it was like, oh my gosh, I get the chills just talking about it. And we got her home. We put that baby in her arms, and she got to be at home surrounded by friends and family. And it was sad, but it was a beautiful, beautiful experience to be a part of. And that's why I do this work, and that's why I've done it for so long. And I'll end with that. And thank you so much for letting me share.
Thank you so much, Janie. That was wonderful. That was a beautiful story. And I really appreciate you sharing it, because both your background and also the story of Audrey, I think that was just amazing to hear. And the insightful information that you shared, I think can help many people. Anyway, we're honored to have you. Thank you. That was a wonderful presentation. And now I would like to introduce Father Peter Daly. We're so honored to have you. Thank you for agreeing to join us. Dr. Meyersburg was, as soon as I told her about this event, she told me about you and Pam, and I'm so grateful that you both agreed to join. And I have taken her class, so I've taken advantage of your knowledge before, but I'd love to have you speak to our audience today. Thank you again for being here. You have the floor.
Thank you very much. It's a pleasure to be here and an honor to be with this panel. And can you hear me okay? Okay, good. I don't have the expertise of this panel, but I've been with a lot of dying people. And so my expertise comes from experience. And I am, and it comes from a particular cultural experience, which is the Roman Catholic tradition of death and grieving. And so those things are what I bring to this, I guess. And I want to say that what we've heard today about the grief process, especially from Dr. Meyersburg in the beginning, about is, there isn't any prescribed way to grieve. And there are various ways, and some people have some kind of prolonged grief, which we might call it pathological or destructive grief in some ways, because it paralyzes them and doesn't allow them to go on living. I have had some experience with people in this kind of suffering, and it's real suffering, because they, you can't just say to people, "Oh, get over it," because they're not capable of getting over it. And but being present is the most important thing that we can do, I think, and that's part of the Judeo-Christian tradition. I guess it's part of every tradition, because it's a human thing to be present to somebody when they're grieving. And my impulse is to want to say something wise or something that will solve the problem. But mostly I realized, as I've been now with maybe several hundred people as they were dying, is that to just listen to them. And after the death, to listen to the family, to be just present to the family and listen to their grieving, and to reflect back to them what it is that they're saying. So they tell you that they've never felt such pain, or they miss their son so much, and so forth. Then it just reflect that back to them. I hear that you are in pain. I hear that you miss your son so much. And I've seen people in grief for many years. I have a friend who was in Vietnam. He was his best buddy was killed right next to him in Vietnam, and he has never gotten over it. Every time he mentions his buddy's name, he breaks into tears. Now, this has been 50 years. And it's still as real. That's the thing about trauma. It's still as real as the day that he experienced it. And I don't suppose he will ever completely get over it, but you can be a comfort to him, a hug, I hear you, and to honor his grief. One of the ways that we honored grief in our parish for years is we had a list of everyone who had died in our parish and the date on which they had died. And so every day, this was now about 60 some years of deaths, I would read the names of the people in the parish who had died on that day. And we have church every single day. So in the morning, we would, at the end of the Mass, I would read the names of the people who had died, and we would say either Psalm 130, out of the depths I cry unto you, O Lord, or we would say just the short prayer for the deceased: eternal rest grant unto them, O Lord, and may perpetual light shine upon them. May their souls and all the souls of the faithful departed through the mercy of God rest in peace. And people told me it was a surprise to them and a comfort to realize that they may have come to church just for no particular reason that day and realized that we mentioned their mother's name or their cousin's name or something. And they said, this is wonderful because Mom died 40 years ago, but she's still remembered. And so that became, even after I retired, that became an institutionalized ritual in the parish. And now there's a little board where we remember people who've died recently. We have their names up on that board, and usually people within the last year or so. And they gather every morning by that board to recall the names of the people who died on that day, and to pray for them. I think that is a way of consoling people, even people who've had prolonged grief. They feel like it's being recognized. I had a very typical situation with a woman named Eleanor. She'd lost her husband of nearly 50 years and in Philadelphia, and then she moved on to Maryland, where we lived, and lived with her daughter. And she didn't know anybody, and nobody had known her husband. And all we knew was she was Janine's mother, and all we knew was that she was a widow. So she carried this grief with her all the time, and it was prolonged. And finally, she felt like there was no place for her to focus her grief. So we put up a plaque in the cemetery. We have a wall of plaques, names and dates, for people who are buried elsewhere, but they're not in our community, but at least where we want to remember them. And so we put up a plaque with the name of her husband, and she would frequently go down to the bottom of the hill and stand there in front of that plaque and pray. And she said it was a real comfort to her that her husband's name was remembered in the new community where she lived. Now, I've discovered that you shouldn't ask people too much about their grief. You sometimes trigger worse reactions that you really are not capable of handling. I'm leaving to go in a few weeks to Ukraine for a second visit over there. And one of the things we're doing on this visit is, besides trying to gather information that will help in the aid to Ukraine, is to talk to people who have been affected by trauma. We're going with, one of the people going is a psychiatrist, and he has a particular interest in PTSD. And so we're interviewing some soldiers who've been affected by trauma. And I made the mistake recently in a Zoom call with him. He was in Kyiv, and I said, "Have you lost many of your comrades?" And it just triggered a fury in him. How dare you ask me that question? It was like I had touched a nerve, and I should have said something more general, like, is there anything you'd like to tell us about your experience in the military? Or what is your experience of trauma? I should have known to do that, but I was trying to be direct, and it's very awkward. When you're on a Zoom call like this, you don't see the people immediately. You don't read their body language. And of course, there was a linguistic problem. I mean, he spoke good English, but we were working through a translator too, from English to Ukrainian. And so anyway, I've discovered maybe it's better to ask open-ended questions when you're dealing with people who are suffering from grief. Just, is there something you'd like to tell us? How are you feeling today? And don't tell them what they're supposed to feel. Just like hear what they have to say. Now I'll stop in a minute because I know that what we bring to it, what the clergy bring to it, besides some theological theories, which really are small comfort to people at the time of death. You know, I buried a good friend of mine about a year and a half ago, who was a very theologically sophisticated. He had been raised a Catholic, but he became a Unitarian. But I mean, he was a person who had read everything about death and dying and on philosophy and theology. And he said, one night when he moved into my house for the last 18 months or so of his life, and I was trying to listen for him. I had open heart surgery just about a month before, so I wasn't in great shape myself, but I could hear him out in the hallway just behind me here, and I could hear his voice calling my name. So I get up, and he had urinated on himself. He was, by this time he was close to going onto hospice. And maybe I think Janie could talk about this. But people often wait to get onto hospice. They don't, because when you enter hospice, it's admission that you're dying, and they don't want to do it. I'm his pastor at the Unitarian Church. So why doesn't he want to get on the hospice? I said, well, for the obvious reason. Everybody gets onto hospice is saying, I'm dying. And anyhow, but we had not yet done it, but the next week we did put him on hospice. But he's standing in the hallway, he's calling my name. I get up, he's in a little puddle of urine. We clean him up, get him back to bed. And he's sitting on the side of the bed, and he says to me, I have to figure out how to get home. And I said, you mean back to your apartment? He lived on Harvard Street here in DC. He said, no. I said, you mean back to Puerto Rico, where he was from, as he grew up? He said, no. I said, well, this is your home now. Where do you mean home? And he said, he just pointed up to heaven. And I realized what he was talking about. I said, Jose, you don't have to figure out how to get home. When you die, God will send a legion of angels to come get you and take you home. And I put him back to bed, and I lay there next to him until he fell asleep. He was unsure, about what would happen at death. Well, we all really are unsure. I remember I saying to my mother when she was just a week or so from death, I said, do you believe in the afterlife, Mom? And she said, I think it's wishful thinking. Now, Mom had been lived as a Roman Catholic for 97 years, and she said, but I hope it's true. And then she recited from St. Paul, eye hath not seen, nor has ear heard, nor has it so much entered the mind of man what God has ready for those who love him. And she said, I think it must be something wonderful, but I have no idea what. And I guess that was a very prudent understanding. So we don't give people a theological answer. We sort of let them work out their own synthesis. One last thing is that we have an order of nuns, the Little Sisters of the Poor, that takes care of people in their last days, and they have a rule that nobody dies alone. If now, obviously, sometimes in their nursing homes, they don't know when somebody's dying, but if they know that somebody is begun the dying process, they make sure that there is a sister with them all the time, so or somebody is with them all the time, and I think that's an important thing, to accompany them to the last, and that's what our rites do. The priest often is called for last rites. People have a misunderstanding that somehow this is like I'm the gatekeeper to heaven. You don't have to get. God does not depend on our ceremonies. I mean, I always say God is in our ceremonies, but God is not a prisoner of our ceremonies. But I do think it helps that we prepare people with a ritual that helps them sort of come to the moment of death. And we have a prayer of commendation and farewell, which is not very, I don't usually say it, but sometimes people do, they have come to the conclusion that they're dying, and they want to hear the prayer of commendation and farewell. It goes something like this: "Go forth, O Christian soul, from the world, to the hand of the God, the Almighty Father, who created you, to Jesus the Christ, the Son of the living God, who suffered and died for you, to the Holy Spirit, who gave you life and was poured forth upon you in your baptism. May you live this day in peace. May your home be with God in the true Zion. May Mary and Joseph and all of the saints greet you as you go forth from this life. We commend you, dear sister or brother, to the God who formed you from the dust of the earth. May Christ, who died for you, bring you freedom and peace. May Christ, the good shepherd, acknowledge you as one of his own flock and set you among those he has chosen. May you see your Redeemer face to face and know the vision of God forever. Amen." And that is often the last words they hear. And so I think it's helpful to have a ritual and to be able to say to somebody, now you have permission to go. And it's helpful to the grieving family to have felt that they did what was right and proper for the person. Now, that will vary from culture to culture. You know, if you're a Buddhist culture or a Muslim culture, or, it'll be different. So I can only speak to my own culture. And finally, one thing that I have known with people from various cultures, and I've buried people who were Buddhists or atheists or agnostics or from Islam. I've buried people from, I guess, every faith. But one thing we can say that universally when somebody is dying is just say to them, I'm here with you. And the same is true for the grieving family, to be there with them. I think the Jewish tradition is very wise in sitting Shiva. You just go and you sit and you remain silent and you wait for the grieving person to say something. You don't go in with you might bring a cake or something, but you don't go in with a solution. You don't go in by saying, here's what you should do. You just go and you listen and wait for them to speak. So I'll stop there and see if anybody has any thoughts.
Thank you so much, Father Daly. That was wonderful. I really appreciate you being here and sharing your knowledge and sharing your stories. Thank you to all of our experts here today, Dr. Meyersburg, Pam Albert, Janie Acosta, Father Daly, and all of our guests. Thank you for attending. And it will be on our website as well. As soon as we get this video together, we're going to put it on our YouTube, and we'll send out the link to everyone, to all of our members, so they can take advantage of it. It will be open to public. And now I just want to do a quick Q&A. So if anyone has any questions, I think the chat should be open, and also the Q&A. I know there are 2 questions. I know one of it, at least, was for Pam.
Yep, I can see that question. I'm happy to try and answer it because I'll try and make it simple. All things about the list is complicated, but let me try and start and make it simple. There is one national list that is subdivided into blood types. So A, B, and O. everyone who, every potential recipient who wants a transplant gets their transplant program puts them on the national list and then puts them on the list for the area where they work. So for me, where we work in New England, any state that you're in New England, you would be on our list, which is also subdivided A, B, and O, and you're on the national list. Can you, there are a couple of things. Can you, do you have to, is it limited to a particular state? So sometimes patients list themselves in 2 different service areas. So we work with 14 transplant centers in the Boston area. You can list yourself on one. You can't be in multiple in the same service area, but you certainly could list yourself in another service area. So sometimes people do that. The difficulty with that is when the call comes, if it comes from the donation service area that's in Florida, you have to get there quickly. So that's an issue. The thing that makes the kidney list a little bit different is there's what's called a 6 antigen match. So it's like getting a kidney from your twin. So when somebody goes goes on the national list, every month in dialysis, they draw bloods, they tissue type you to make sure that they have the best antigen match. So when we recover a kidney, it's run, those antigens of the donor are run through the national list. If the donor's in California, but in Massachusetts, there's 10 people who have the same tissue typing. So those 10 people could be number 1 or number 5,000. They go up to the top of the list because the best match is one that's where your antigens are similar, where you are least likely to have a rejection episode. Then how do you break a tie? Who's been on the longest? So yeah, it's complicated in that, but people tend to stay in their service area just because when the call comes, you need to go. But when we talk about organs, the major differences are for kidneys can be on a pump for a couple of days, so it gives you some time to travel. Livers can be transplanted in 24 hours. Thoracic organs like hearts and lungs, 4 hours from time that they are removed from the donor to be recirculated in the recipient. So if I was a heart patient in Boston, maybe a donor from Washington, D.C. would work for me, but a donor in California would not work for me. So I hope that that answers the question in regards to you have priority for the kidneys in your service area unless somebody is a 6 antigen match anywhere in the country. That's of all the kidneys that you could get. If it's not from a family member, that's the one that most people hope that they can get because they're so similar. It's as if they are twins of each other. I hope that answered the question.
Thank you so much. And I think there's a question by, let's see, Danielle. I think she posted it and I believe, let me see if Father Daly answered. I don't know if you guys want to answer her so everyone else can also take advantage. I don't know, Dr. Meyersburg or Father Daly, if you guys want to jump in and answer her question so everyone can take advantage of it and hear it because it's being recorded.
I completely agree with Father Peter Daly. You have every reason to be upset. I remember when my grandmother passed away and the people who did the service wanted to show off their beautiful makeup skills. And even though I had requested closed casket, my family requested closed casket, they opened the casket to show off how good they were at makeup. And my last vision of my grandma, she looked like a grandma piñata to me because she had all this makeup on that she never would have worn that made her look like some sort of weird doll. It was creepy and I was mad and it was just to promote their business. So no, personally I relate to it, but intellectually I also think completely reasonable to be mad. And things that would upset you are going to upset you more right now because you're grieving. And it's like I was saying, it's like being like once a year crabs shed their shells and they're soft and can be hurt then. Most of the time they're protected by the shells. When you're grieving, it's like your shell's off and you've got this soft shell that isn't protecting you as well as a shell normally protects you. and it makes things that hurt even more. So absolutely, completely reasonable in my book to be angry. I deeply disapprove of the monetization of grief, and I think it's not how it ought to be. But there you go.
Right. Just one, yeah, absolutely agree with Danielle. She was right to be angry. There's really no permanent solution to this problem because there's money to be made in death, in burials, and in caskets and all the other things. In my time, which is 40 years now since I was ordained, the death industry has shifted from traditional burials with caskets to cremation. Now more than half of the burials are cremations. And people are quite at home with that, but you still, in many states, have to go through hoops. You have to get to authorize a cremation. So, but I think it's worth doing ahead of time, and this is why it's important to talk with your loved one before they enter into the dying process to find out what do you wish to have done and how do you wish to have it done. And I went with a good friend whose partner had died, and he wanted we went into the funeral home, and this is just a little over a year ago, and it's a national chain. It's one of these national chains of funeral homes, and we had options for disposition. Where will the ashes be disposed of? And you could take them home, you could take them to the cemetery. We have a veteran cemetery, and then she says, we have also space burial. And I said, what? This is the first time I've ever heard of this. Talk about the commoditization of death. They will make arrangements to shoot your loved one's ashes into space. And I said, how do we have any proof that such a thing has been done? I mean, how do I know that you just didn't bury them in the parking lot? I mean, and where it was $12,000 to $15,000 to have the ashes shot into space. And I said, you're kidding me. I said, and I said, has anybody, I asked the young woman who was, she was just doing her job. She was just saying, I said, has anybody ever done such a thing? She said, no, I've not actually sold one of these packages. And I said, well, with good reason. But I said, I think it's absurd that you people offer this, Anyhow, yes, there's a lot of commoditization of the death industry, and there are a lot of people who want to take advantage of somebody at a vulnerable point to make money, and it's good. That's why it's good to plan ahead. My mother did planned ahead. Remember, we walked into the casket room in Baltimore, where the funeral home where she was going to be laid out, and she said to the guy, which is the cheapest? There's a big array of caskets in the room. She said, which one is the cheapest? And he said, well, it's way in the back here. And he said, do you want to see it? She said, no. She turned to him, she said, it's going in the ground, And so he said, okay. And so then she turned to me and said, let's go to dinner. And so we left. But she didn't, I think she was quite right. Just pick the cheapest one and go to dinner.
Thank you so much. If anyone has any questions, I can't really see people raising hands because I don't know how to operate the webinars raising hand thing. But if you put it in the chat, we can make sure to get your questions answered. And I also have a question for Janie regarding hospice. I just wanted to know more about hospice and memory care patients. And how you handle that, especially with families, because it's more difficult because the patient can't really consent. So if you can speak a little bit on your experience on that, because I know you have a great experience with memory care and hospice. So thank you.
Yeah. So for those diagnosed with dementia, there is very specific criteria on whether they qualify. So they have to be at a certain stages of dementia, so advanced dementia. Maybe they're no longer able to speak, they say 6 or less intelligible words, they're wheelchair bound, they can't perform any of their ADLs, and obviously cognitively not able to communicate or consent. But the family or power of attorney is allowed to consent for them to sign them onto hospice. And that's typically what we do. We meet with the family, explain that, dementia is progressive, and, whether they end up, well, most often what I've seen with dementia is they end up, they stop eating. That's sort of the last choice that they have, is to be able to take food in their mouth. And they'll just stop eating. And so that's usually what will get them to that point where they're going to transition. And without food or water, at all, they typically last around maybe 7 days, and they start going through that dying process.
Thank you so much. Thank you. And I see that Amber wrote she has a question. Amber, I think you can just ask. Thank you.
Yeah, I just had a question, and maybe it's more for Janie. Um, just recently, I've been in conversations with people about hospice, and either someone in a friend group or even in my own family where it's like, well, maybe so and so needs to be in hospice care, or there was a recommendation for a family member to be in palliative care. Um, those are very difficult words to grab onto and accept, palliative or hospice. How do you have those conversations or talk to people? Because, or I took like another class, and which was so helpful for me in understanding, what these words really mean, that, these are great helps and resources, take some of that fear out of it.
For me, it goes back to asking the question and getting information from that patient and their family about, tell me what's been happening in the past 6 months, tell me what's going on. So then you can kind of meet them where they are with what's happening. And once I've kind of identified what the needs are, maybe they're in a lot of pain, maybe they need medical equipment. Well, did you know that hospice provides medications for pain? Did you know that hospice provides a wheelchair and a bed? People can be on hospice for 6 months or longer. Most people, and I think Father Daly mentioned, people don't want to accept it till the last days of life. And that happens. This recently happened with one of my aunts who had pancreatic cancer. She had her wits about her, and she was not going to sign on to hospice as long as she could get up to go to the bathroom by herself. And she signed up a week before, and that's just where she was at. And even though the family knew she needed it, she still had that choice. So it's just planting the seed, letting them know the support that's available, and then when they're ready, hopefully they'll accept the help.
May I add on? First of all, Janie, I haven't met you before, but I was so impressed by your presentation. It was such a joy hearing you speak. I can see why
Thank
Kimia
you.
was so excited about having you be here. And
Thank
it's
you.
really a joy. I'm a big proponent of hospice. I always make sure in my grief class we cover hospice. And one thing is demystifying hospice ahead of time so people have it in their heads before. Same reason it's very important to me to have Pam Albert come when I teach about grief, is if people have had a chance when it's not a terrible situation to think about it in advance, when it's not the worst day of their lives or the second worst day of their lives, something horrible, and then they've made a decision and know what it is when they're not too upset to process information. I find that people are then able to process it and make better decisions, and decisions that involve less suffering. So for instance, when my mother-in-law was dying, they thought she was going to live 6 weeks. She lived 9 months in hospice, on home hospice care. Made her much, much more comfortable in the last 9 months of her life. I'm very grateful. My mother, we did home hospice for the last 3 months of her life. The earlier you can get hospice in, the more comfortable people typically are. And I'm a big fan of that. And I think that the notion of giving up on someone living is something we need to set aside. Instead, frame it as, sometimes people come out of hospice care. I have a friend whose father-in-law came out of hospice year. He lived another 3 years and then died. But he graduated out. He was no longer in such discomfort. He ended up more stable, and he ended up so I think leaving the door open for a tiny bit of hope for people is nice. I mean, we're not, most of the time we know what's going to happen, but we are taking our best guess about what will happen. We don't have a perfect crystal ball to view the future. So I think leaving the door open for a little bit of hope, having people make the decision ahead of time, and having them know that it's not somehow giving up on a loved one. It is just trying to make sure your loved one gets to enjoy his, her, or their life as much as possible. And Janie, thank you for what you do. Hospice is hard work.
Thank you.
Thank you all so much. I want to thank you all again for being here. And Dr. M, I don't know if you just want to give them a little shout out about your classes if they want to take advantage of it, and then we can wrap it up. But thank you all.
Oh, it's such a joy hearing everyone present. These were such great presentations. So Pam and Janie and Father Peter, thank you so, so much. It was really an honor to get to be on a panel with you. And for you to take time on your weekend to do this is just so kind and so lovely and so needed. I teach a class on grief. I mentioned it already, but I get very high percentage of students who give very high ratings for it and send me other students. It's usually full. And so sign on, but because I'm a soft touch. So if it's full and you want in, and I'll make space for you. That's the joy of a Zoom classroom, is they don't run out of chairs. And it's really meaningful. And there isn't an exam. Sometimes people ask, well, what sort of an exam do you? There's no exam. You do you're writing every week, you're creating a portfolio, you're giving a presentation. It's really aimed at, it's hard enough material. It's aimed at being something that's an enriching and educating experience where you learn and do a lot of reading and a lot of talking and thinking, but you don't have to do any memorizing, nothing like that. You're putting your portfolio together bit by bit over the semester with your response papers, and then you put it together with an introduction and conclusion at the end, and you can add other things to it. So I've had some really gorgeous, thoughtful, wonderful portfolios come across my desk, and I love them. So I hope I will see many of you in my grief class. And in addition, I have a Loss and Legacy weekend, which is an optional add-on. I want to do that. I have some other also wonderful speakers who participate in that and some wonderful experiences. So I really hope I'll see you in grief.
Thank you so much. And again, thank you, Dr. Meyersburg, Pam Albert, Janie Acosta, Father Daly, and all of our guests that are attending this live. And I know our global community will be also joining on YouTube. I know this video is going to serve many people through the years, not just right now. And I think some very important topics were discussed that it's honestly, it's difficult to come by in our world, even though we deal with grief every day. And I really appreciate you guys sharing the stories that were so touching. And I hope it serves as a beacon of hope for everyone grieving right now, because I know there are many, unfortunately, grieving. I think this gave them hope to see the light at the end of the tunnel. And I really appreciate all of you. Thank you.
Thank you. Thank you for organizing this, Kimmy. It was wonderful.
My pleasure. Thank you guys for being here.